Thank you. Good morning, everyone. Thank you, Kwame Williams and your drumming crew. On behalf of the Black Scientist Task Force for Vaccine Equity and the Taibu Community Health Center and the City of Toronto, it's my pleasure to welcome you all to the Black Health Fair and Wellness Summit. Thank you for your patience. We're going to start without much ado, and I'm going to invite Kemba Byam, who is the acting manager of the City of Toronto's Confronting Anti-Black Racism Unit, to come and do the land acknowledgement.
Good morning, everyone. Really honored to be here and want to give thanks to the Black Scientist Task Force for inviting the Confronting Anti-Black Racism Unit. We have a table outside. I'm going to start off with a land acknowledgement that was written by Elder Kay Johnson. So I want to first give thanks to that elder for giving us permission to use this land acknowledgement. Just going to adjust my mic. As people of African descent, we offer this land recognition in solidarity with the Indigenous peoples of Turtle Island in the efforts and deliberate intentions towards decolonization. We acknowledge the lands of Turtle Island that were never meant to be owned. We recognize that most of the land that was entrusted to the Indigenous peoples was in some cases shared by choice, but all too often taken by force. We recognize the historical colonialism and the ongoing colonialism that has led to the present day situation where land acknowledgements are offered in place of land. As people of African descent, many of us have come here by choice, while many are here as a result of historical force. We acknowledge the complexities where we were promised land that were never given by those whose it was never to give. As people of African descent, we acknowledge the land of Turtle Island that sustains us, express deep gratitude to its Indigenous peoples, and pledge to honor our dignity and divinity that ultimately connects us all. We say Ashe, we say Amen, Amin. Thank you so very much.
You know, it's so good to see you all here this morning. We're very excited to have this event. And as you can see, we have a lot of things in store for you. And I'd like to thank the health specialists, the vendors, DynaCare, everyone who's participating in this event today. The Black Scientist Task Force has really, for the last 2 years, been engaging with the community on issues related to COVID, the pandemic, and addressing many of the valid concerns and questions that the community has had around the virus and vaccines. And I'd just like to show you the members of the Black Scientist Task Force. Oh, there we go. So the task force is really made up of some of the most talented scientists, medical doctors, healthcare practitioners, naturopath doctors, nurses that are in Ontario. And I'm very proud to work with these individuals, and you'll see many of them around today. I'm not going to go through all their names, but look at their faces and just drop their masks to see if you can identify the ones who are on here. I have to say a shout out to Dr. Akwate Kenti. He has been really the driving force for this task force, and I think we should give him a big round of applause for the work that he's done. Candice Todd and myself are the current co-chairs. And I also want to say a few words about some people that without their help, we would never be able to put on an event like this. And we'd never be able to have a task force that has been so successful. So that's Ika Washington, who's on the left there. A big round of applause for her. And also, I'd like to shout out for Nina. Nina, where are you? She's up there. Take a wave, Nina. Nina's been coordinating. She's the project manager for this event. Now, many groups have really supported our community during this pandemic. But the Black Scientists Task Force, I think, is very special. It was established for the community during a major health crisis. And to our knowledge, it is an extremely unique situation to have a task force made up of Black health professionals set Toronto came in second place out of 60 cities in the world. And would you believe it? The Black Scientists Task Force was specifically mentioned in that article as one of the community-specific initiatives that helped to make the city safer. So I think we deserve some kind of commission from the City of Toronto Tourist Board. Anyway, on a serious note, the last 3 years of the COVID pandemic has exposed the health inequalities that the Black community has faced. And we know that the anti-Black racism and systemic discrimination that has gone on for decades, if not centuries, has seriously negatively impacted not only our socio-economic status, but also the health outcomes of our people. So today's event is a call for the Black community to retake control of its health. And the message is, our Black health matters. So this event today focuses on two components that will help us to achieve this goal. The first concerns things that we are mostly in control of. The health and wellness fair, all the booths, the practitioners, the diagnostic testing, and the vital signs evaluation that nurses will do today, and the vaccine clinic, these services provide us with the information and the tools and the demonstrations to help us to live healthier, happier, and longer lives. The second component of today's event, the summit that's taking place on this stage, is really focused on an area that we have more limited control over. But we must respond to it in a more powerful way. And it's the impact of systemic discrimination and anti-Black racism on the health of our community. Martin Luther King said, of all the forms of inequality, injustice in health is the most shocking and inhumane. And so this summit will take place here and will focus on reinforcing and further developing community-led strategies to dismantle the structural barriers to Black health and wellness in relation to economic equity, housing, education, food security, and public health. And I hope you'll take advantage of all of the facilities and services that we have here today. The free food, entertainment, Socus Eyes, the Children's Corner, the Black Scientist Museum, and of course, Flow 98.7 and Red will be covering the event live. So without further ado, I declare the Black Health Fair and Wellness Summit officially open. So I'd like to invite the co-chair of the Black Scientist Task Force, Dr. Candice Todd, to give the first presentation on Black health checkups and healthy living, our purpose, our vision, and our strength.
I haven't worn heels in 3 years, so a little bit of a challenge. Thank you, everyone, for coming out tonight, or sorry, who knows what time it is this morning. My name is Dr. Candice Todd. I am a naturopathic doctor, and it is my pleasure to be speaking on the Black Scientist Task Force today on our vision, our purpose, and our strength. You know, the Black Scientist Task Force, as Dr. Burt was saying, was put together in the height of the pandemic in late 2020 to address the glaring inequities faced by the Black community with respect to COVID-19. We were experiencing disproportionate numbers in illness, in death, and in some of the socioeconomic factors that impact health overall. And I wondered, you know, what does a naturopath have to offer in this space? It's really a unique position to have a naturopath on a task force of this caliber. Dr. Burt was showing you some of their pictures. I'm going to highlight some of them today, but really my imposter syndrome kicked in, and I questioned daily, why am I here? What am I doing here? How can I contribute to a conversation about vaccine hesitancy and COVID in general? And the vision became clear, and it was really Dr. Kenty's vision to have lived experience on the task force. So we all know that as Afro-Caribbean people, our first line of defense is what? We look for the tea, yes, we're looking for the bush. We mix some rum and some ginger and some honey together, and that's healthcare. So it was really important to address some of the myths in that area, and speak to our strengths as well, because there are a number of herbal remedies that can help to support your immune system, and that was the other part of it. Too, you can't have a conversation about vaccines and COVID without having a conversation about supporting your immune system. They work hand in hand, and Dr. Kenty really envisioned that. So, and it's something that speaks to our community as well. And 3, COVID really shone a light on the, again, inequities faced by the Black community with respect to COVID specifically, but we know that this problem didn't start in the pandemic. We know that across the board, we face inequities when it comes to health and wellness, and it is truly a full circle moment for me as a naturopath to have this event today where we are addressing COVID and the pandemic, but we're also addressing all of the health inequities and the barriers to health that Black people face. And, a real full circle moment, because it's also my birthday today. So thank you. So, yeah. Aquarius season, yes. It's truly a gift for me to give back to the community, to have you all participate in our the offerings that we're having today. We have DynaCare here, as Dr. Burt was saying. We have our health and wellness practitioners here. If you have never seen a chiropractor or gotten a massage or a stretch before, this is your opportunity to experience those things. Some of those allied health experiences are not accessible in the Black community, and we wanted to bring them to you here today. I encourage you to take advantage of our health information booths. Get educated on your health, on prostate cancer, on breast cancer, on hypertension, diabetes, all of the things that impact Black communities the most. Because at the root of our resiliency as a community is our health. And I really need you guys to take that in. You can't be amazing mothers to your children if you're tired all the time. Your children can't prosper in school if they're hungry and they're not getting the right nutrients. You can't take your kids to their practices if you're stressed out and anxious. So there's so many things that impact us, and we wanted to bring it all back today and have you enjoy this wellness summit and health fair. The conversations that we have today are the things that live on in the future, and those are the things that are going to shape generations to come. So I encourage you to participate in the panel discussions that we're having. Again, make sure that you access all the services and get that information. I did want to highlight some of the people that you will see today. This room is full of talented, knowledgeable, impressive people. All of you are impressive, but I do want to encourage you to see yourselves in the faces of some of the incredible people that we have on the task force and that we have with us today. So I did want to highlight some of them. Soon, perhaps. Okay, so these are 5 people that I picked out of, the many, many people that we have today. We have Dr. Zainab Abdurrahman. She is a pediatric and adult allergist, the assistant clinical professor of pediatrics at McMaster University. This is slow. Yeah. Oh. We have Dr. Nikasa Remy here. She is a doctor of chiropractic, and she's also a media personality. You might have seen her on Cityline as well. She'll be offering chiropractic services for you guys today. We have Dr. Upton Allen. He is the division head of infectious disease at SickKids, as well as the senior associate scientist and at SickKids and professor at the University of Toronto. Sorry. And next we have me, birthday girl. Thanks. Would have never thought I'd be, in this position as co-chair of the Black Scientist Task Force, but again, it's really come full circle, and here is where exactly I'm supposed to be. I'm a naturopathic doctor and the co-chair of the Black Scientist Task Force. Oh, and finally, Dr. Kwatu Kenti. He is the Director of Community Resources at the City of Toronto and Assistant Professor at the Dalla Lana School of Public Health and Senior Scientist at CAMH. He has been the visionary for this task force. He saw the vision, and I hope that You can all see the faces of your children, yourselves in these faces as well. Welcome to the Black Health Fair and Wellness Summit, and have an amazing day, guys.
Candice kept that quiet about her birthday. Anyway, thank you, Candice. We're going to start with the first of our keynote addresses, and this will be given by Dr. Isaac Odami. He's going to speak on dismantling anti-Black racism in healthcare, the life-saving potential of race-based data. And Dr. Odami is the hematology section head in the Division of Hematology, Oncology, and the medical director of the Global Sickle Cell Disease Network at the Center for Global Child Health at the Hospital for Sick Children. And he's also a key member of the Black Scientist Task Force. Let's welcome him to the stage.
Thank you very much. It's a real privilege to be speaking about this important subject. I think the topic is so important because if there's no data, it is not officially seen. And therefore, the topic for this keynote is dismantling anti-Black racism in health, the life-saving potential of race-based data. And I think what we learned from COVID was that it was the generation of race-based data that revealed the stark inequities underlying the COVID pandemic, which resulted in the creation of this task force. So because we're talking about data, I think we ought to know who we are. Who are Black Canadians? We form 3.5% of the Canadian population, but it is higher in the province of Ontario. So Ontario really is a place where we have the highest concentration of Black people. But what is interesting is that nearly half of Black Canadians were born in Canada. They are Canadian born. They have their stake in this country. They've been born here. They've lived their lives here. And if you go to Nova Scotia, we've had Black communities that have existed here for centuries and that migrated here as a result of enslavement in the United States, and they're seeking freedom, and even enslavement in Canada as well. And then, of course, we have recent migrants and past migrants that have come from the Caribbean and that have come from Africa. But what is systemic racism, sometimes called structural racism, institutional racism? It's the process of racism embedded in laws, policies, practices of societies and its institutions. So that is what makes it systemic. It is embedded in these pillars of society so that even when people pretend it's not there, it is still there. It provides advantages for racial groups deemed to be superior. So you can't have racism without having a situation in which one race is superior and the other is inferior. So that is implied in the definition. And differentially oppresses and advantages the neglected racial group. But what about anti-Black racism? When you take systemic racism and you now focus it on anti-Black racism, it is defined by a specific form of racism rooted in the history and experience of enslavement that is targeted against people of African descent. Race was never a thing until it was defined purposely to enable enslavement of people of Black descent. And there are various myths, and these myths justify slavery and the torture of African people. that Africans were biologically different, they were subhuman, they were less intelligent, they have greater tolerance for pain, they are not to be trusted. These are all the myths that created anti-Black racism. But the statistics and the data tell the story, and that's what we're going to focus on today. To tell the story clearly and make it very compelling, you need data. Why is it that over half of Black Canadians report experiencing discrimination in the past year? The same for Indigenous people. And less than 15% of white Canadians have such a complaint. They are profiled on the streets, nearly 40%. In the workplace, they are discriminated against. In schools and universities, even when they are shopping in the stores and eating in restaurants. In all these areas, data has shown that people of African descent have experienced discrimination. But this is the CDC data, which was so revealing on COVID and its outcomes. If you took all the data together, there was no way you could see these inequities. But when the data was disaggregated into American Indians compared to the white non-Hispanic, Asian non-Hispanic, Black, African American, and Hispanic and Latinos, it was clear that if you look at the number of cases, if you look at hospitalization, if you look at deaths, Black Americans were overrepresented by far. 2.6 times the cases, 4.7 times hospitalization, and 2.1 times the mortality. And what is clear in this data is that race and ethnicity by themselves are not the risk factors, but they are pointing to inequities in social status, access to health, increased exposure to the virus in terms of occupation, being frontline staff, being essential workers, and having infrastructure workers who were faced with the pandemic at the front end. So racism was at the forefront of the pandemic, which established the Black Sciences Task Force. Dr. Phillips, an epidemiologist, said that racism, not race, is a risk factor for dying of COVID-19. And this disparity is due to racial inequities deeply ingrained in society. Systemic racism has a twofold effect. Number one, racial minorities are more exposed and less protected from the virus. And number two, when they get infected with the virus, they are more likely to die because of inequities relating to health and environmental factors. So these are what we call the determinants of health: the environmental factors, the social factors, the work opportunity factors, income, housing, all of them coming together to impact outcomes. So the racialized effects of COVID is systemic. It's systemic in that healthcare itself manifests racism because racism reduces the quality of healthcare experienced by people of minorities. If you talk of well-controlled diabetes, well-controlled hypertension, if you talk about weight control, if you talk about access, quick access to care for chronic disorders, people of African descent are disadvantaged. And then labor, the kind of work that people do. The infection in the workforce reflected wider problems of racism in our economy in most racialized who are unable to work from home. Some of us were privileged to be able to work from a distance, but if you were front-end staff, you had to be there in person. And of course, even if you were sick, you didn't have paid sick leave to be able to get off the workplace. And then housing and community support were all factors that became clear during the pandemic. So these disparities, we know for sure, are not explained by biologic differences. The Genome Project totally ruled out any sense that these disparities are because we are biologically different. And I recall when the Genome Project was being announced as being completed in the White House, a statement that President Bill Clinton said, and I remember it very well. He said, today, we have a scientific evidence that racism has no basis because we are not biologically different. Race is a social construct based on nationality, ethnicity, and other markers of social differences. And it reflects differential access for Black people to power and the resources, power to enact policies, power to change society, and the resources to be able to do that. It drives societal factors that perpetuate inequities in health for non-dominant groups around the world. And everywhere around the world, this factor has been well established. Drs. Dryden and Norum, actually in a very well-written article in the Canadian Medical Journal, made some recommendations as to steps that we need to take to dismantle racism in healthcare. The first is this, that healthcare providers must acknowledge the existence of anti-Black racism in Canadian systems. Without that acknowledgement, no efforts will be meaningful. It is notable that since Black Lives Matter movement was launched, virtually every health institution in this country has an EDI wing. They are all trying to make efforts to bridge the gaps. But it has to come from individual acknowledgement and institutional acknowledgement as well. And it has to be followed by commitment to meaningfully and sustainably effect change. That is an important step. And to do so, they have to listen to Black voices. They have to listen to patients, their families, healthcare professionals who grapple with anti-Black racism every day of their lives. It's not even just historical things. It's the everyday experience of these disparities that people face in their health communities. Engaging the communities who have made recommendations for change. For example, the UN Working Group of Experts on People of African Descent, the Black Experiences in Healthcare report in 2020, the Black Medical Students Association of Canada, who have made a significant impact on medical education for Black people, access to medical schools, and of course, the Black Scientists Task Force on Vaccine Equity, that the voices of these experts who represent the community need to be heard. But one final point they made, which we are going to focus on, is that we should collect disaggregated race-based data across Canadian institutions. Because if the data is not known, if it has no number attached to it, if it has no percentage attached to it, in comparison with the majority white population, there's no way we are going to make progress. But often, I always feel awkward because it seems to me that I'm preaching to the choir here. Because really, the entire community of Canada needs to be committed to this. And in this sense, I want to say that it is not a matter of shame and guilt. Shame and guilt alone felt by one race or the other will not bring about change. But it is a feeling and a sense of responsibility. That is what matters. Race is a social construct, and there's no biologic basis for it because more and more evidence is being generated in genetics and in molecular science that there are more differences in genetic material within races than between races. And so race is not the basis, biology and molecular biology is not the basis for which one could establish racism. And I have to say, there is no Blackness without whiteness. If you don't have whiteness, you can't have Blackness. And the reason I'm making that point is that the solution of systemic racism requires a collective sense of responsibility and not a mere sense of guilt and shame, which often is what people feel. But we should move beyond that and go to responsibility to dismantle this. And I want to propose that the majority of white Canadians should be equally engaged with the minority racial groups. And such fora, we don't see the majority white population. We talk to ourselves, we feel it, we know it. But the key partner that we need is the majority white Canadians out there. For all of us to feel a sense of responsibility, even if we feel uncomfortable about the shame and the guilt that Indigenous people have felt, that Black people feel. We need a collective sense of responsibility. And not only us, it has been emphasized that data collection is a key to this activity. Across the world, racial and ethnic data and statistics play an extremely important role in the elaboration and implementation and assessment of policies aimed at combating racial discrimination. If it's one thing we are ending on as a task force, we need race-based data, because that's the data upon which our advocacy efforts will be founded. The UN Committee on the Elimination of All Forms of Racial Discrimination and the European Commission Against Racism and Intolerance report that accurate data is essential to reveal direct or indirect forms of discrimination and to elaborate sound anti-discrimination policies. Because often, when you've raised the issue, the question is, show us. Where is the evidence? And that's why accurate data is needed. We need data collection to reduce the disparities to overcome COVID-19. And that's what we learned during the pandemic. That inadequate data collection about the spread of COVID-19 really is a human rights failure. That's what Dr. Masako in 2019 said. It ignores or obscures the differential impact the pandemic has on particular communities. And this can result in failure to address particular structural factors and produce poorer outcomes, and thus perpetuating discrimination. For example, the right to safe working conditions demands that the collection of such data and action is also applied to the workplace. So how can race-based data help to end disparities? To be able to have sound policies against racism, decision makers need to correctly grasp the scope of the problem, the magnitude of it. Like the CDC data revealed that Black Americans were more than 2 times likely to die from COVID-19 infection. They must be able to identify the people who are exposed to discrimination, in what areas of discrimination, and what is the nature and scale of these discriminatory experiences. All these are important to be able to effect targeted interventions at these discriminatory practices. Reliable statistical information on circumstances of members of vulnerable groups in alternative healthcare settings is absolutely crucial. And we need to acquire deliberate, comparable statistical data to assess policy and program impact and effectiveness. You know where you begin with. When you have an intervention, you can measure whether you're making progress or not. If you don't have the baseline data of where you're beginning, you have no idea that your interventions are making an impact. And often, what is so sad about such situations is that even the interventions that are tried by the system are ineffective, are not well evaluated. And so they have interventions in name, but their impact is minimal. The processing of personal data is necessary for the implementation of certain types of positive action measures. And we're going to talk about the uncomfortable side of that, of collecting personal data, because there are dangers to that as well. To drive positive change, you need data so that positive action can take different forms, which do not necessarily involve preferential treatment. So I think this is a key point. That the point we are making is that we don't want to be treated preferentially. That's not the issue. And that's what people say, all lives matter. We believe that. But we are saying that there are inequities that require specific actionable steps. And to do so, it has to be focused on disparity reduction. So there has to be a disparity reduction plan and an equity initiative aimed at remedying the under and overrepresentation of disadvantaged groups. So there's this theory of overrepresentation and underrepresentation, the disproportionality index or the disparity index. The disproportionality index is a measure to identify the overrepresentation or underrepresentation of racial groups in a program or system to their presence in the population, whilst the disparity compares the outcomes of one racial group with the other. And that is what the CDC data and the data generated by the City of Ontario on COVID revealed. If you have equality of outcomes, your index should be equal to 1. But if a racial group is overrepresented, the ratio of 2 or higher suggests significant racial inequality. And in the case of underrepresentation, if it's less than 0.5, then it is significant. And these are metrics that can be used as a way of measuring the scope and the magnitude of disparities within racial groups. But there's a tension here. On one side, we need to combat racial discrimination by collecting sensitive data to help direct policy development. On the other hand, there are concerns regarding privacy. Collecting this data will infringe on people's privacy and their rights to personal protection. And the idea of classifying people into racial categories is in itself contentious, as it may conflict with the rights of self-determination. And when the data collection is sensitive and relates to health issues, people have concerns. What will this data be used for? How will I be disadvantaged because this data is being collected? So how then can data be collected to combat racial discrimination while fully respecting the rights of individuals? It's a tension that needs to be resolved, and it can. The fact that there's a tension doesn't mean we should not collect the data. I'm stuck here. There we go. So there's one side, the realization of privacy protections are needed in an emergency to collect data. And in this regard, blanket authorization under the Ontario Emergencies Management and Civil Protection Act allowed the police, firefighters, paramedics to access personal medical records to check on people's COVID status. This was a blanket mandate that was given because of the emergency situation. How such privacy realizations meet the principle of strict necessity is unclear. There's no indication that the people are informed that the police can access their personal health information, nor is it clear how such access enhances the pandemic response. So paramedics were given that blanket thing to be able to access people's records to know their COVID status. And this paradox, the other side of the paradox is that privacy concerns around new forms of digital surveillance. For example, in the province of Alberta, they launched a voluntary COVID-19 mobile tracking device so that you will know whether somebody has COVID close to you. Privacy experts have raised numerous concerns. Number one, the user control of data, collection of identifiable information. When is this going to end? When does it begin? When does it end? Is the data accurate at all? Is somebody going to make money out of it? And we know that has happened. This data that is being generated, somebody will be extracting them and monetizing it. And data used for this particular purpose could be extended for criminal investigation and prosecution in matters that relate to the law. So I mean, admittedly, there is concern within our communities about personal data collection for this reason. So what are the safeguards? How do we make sure that in collecting data, which we need for policy direction, for being able to assess the scope of discrimination, how do we safeguard the harmful uses of data? Collection of racial and ethnic data raises questions and concerns, but it's also a tool that can be used to fight discrimination. We must ask the valid questions. What are they going to be used for? Who is going to have access to them? When do they stop? Is it voluntary? Do I have to give permission to have my data collected? What extent and under what circumstances personal data be collected in the fight against discrimination while fully respecting the rights of the individuals? And the human rights standards and the rights of privacy should not preclude data collection once essential safeguards are respected. I know people within our community who are so worried about the safeguards. They don't believe that there are enough safeguards. They become so untrustworthy of the system. They don't trust the system. And so they are not too sure whether this is the right way to go. But without data, we will not be able to make the impact we want to make. The purpose of collection should be clearly stated. There should be no ambiguity about why the data is being collected. And it should be used only legitimately for a specific purpose. Of course, consent has to be given. And to me, I think that's where the key is. If you look at the Emergency Act in Ontario, where paramedics were gathering information, people were not even aware that that information was being accessed by the paramedics. No more data than is required should be collected. Just sufficient, legitimate collection of data to be able to do the job. And race-based data should only be collected for equity purposes. It must be directed only at an equity plan to remove discrimination and to remove inequities. And it has to protect the human rights and personal data that people have given. But the most harmful aspect of data collection is when data, race-based data, is actually used to develop algorithms for clinical intervention. In fact, there are so many examples. I've picked only 3 examples. So let's take a clinical guideline of the American Heart Association on heart failure risk scores. So these risk scores matter because if you score higher, it means that you are at a higher risk and you are more likely to get an intervention. So clinicians use these risk scores to decide on what interventions to give for a patient who has heart failure. Now, in this guideline, this algorithm, if you were non-Black, you scored additional points. Okay, so if you were Black, you scored lower points. If you were non-Black, you scored higher points. What does that mean? It means that if you were Black, you were less likely to make a high-risk call and less likely to receive the higher level of intervention that is required for heart failure. And so this could direct care away from Blacks. Another one, which relates to cesarean section. So this was an algorithm that was developed to look at whether to try labor for a mother who is previously had cesarean section. And in this algorithm, it predicts a lower likelihood that the Black mother will be able to have labor successfully after they've had cesarean section, which implies that Black women are more likely to have repeated cesarean sections. And we clinicians know that cesarean section is associated with poorer outcome for mother and poorer outcome for the baby. So clinicians practicing in the US have no idea. This algorithm is embedded in the system and it influences decision-making all the time. Let's take the justice system. The criminal justice system uses recidivism prediction. Recidivism is the likelihood that you are going to reoffend. And this system, called the COMPAS, the Correctional Offender Management Profiling for Alternative Sanctions, is used to determine the amount of bond, the bond amount, and even prison sentences. Now, if you were a black offender in that system, you scored a higher mark. And so it means that if you were black, you were more likely to have your bond amount increase. You were more likely to have a longer jail sentence because you were merely black. And so this really cements racism into practice and policy. It is the most devastating form of using race-based data for harm and not for good. And we have to be aware of these elements as well. We must understand what the data is going to be used for. The intent must be to remove inequities and to bridge the inequity gaps. Therefore, some authors, Drashali and others, have said that there are 3 questions one should ask when you collect race-based data that is going to be used to develop a clinical algorithm. First, is the need of the race correction, and the race correction is either they score more points if you're black, or you score lower points if you are black. Is it evidence and statistically supported at all? Are there confounders? Are there biases in that interpretation? And is there a plausible causal mechanism for the racial difference that justifies a race collection? So it's something like measuring your kidney function. There's an algorithm that they use. They measure something called creatinine, and the creatinine is used to determine what your kidney function is. For blacks, your creatinine has to be higher. And this is based on the fact that black people have bulkier muscle. But I think we can all agree that not all of us are bulky here. And there are many white people who are much bulkier, have more muscle than we have. But every time you do a blood test, and that algorithm is used to predict your kidney function, it means that your kidney function has to be even worse to be able to get the same value. So if we are taking a decision of whether you need a kidney transplant or not, you are disadvantaged because yours has to be very bad before you meet those criteria. These forms of racism are so harmful. They're using race-based data, all right, but that race-based data is not causal related. The reason they are putting it there is because race is only a pointer to other social and economic determinants in the system. And we must guard against this. And this New England Journal article begins to question a lot of algorithms that are used in clinical practice today, that we need to retool them because that's devastating. So what is the Ontario anti-Black racism strategy? This vision is evidence-informed public system that supports the equitable health and well-being and prosperity of Black Ontarians. And the goal is to dismantle structural racism. It's not easy to do, but it wants to address disparities that foster the health, well-being, and prosperity of Black individuals with these following objectives: centralizing the voices and experience and the needs of Black people. So the voices we have here today is a good example. Collecting, analyzing, reporting, and acting on race-based data. Now, the reporting and acting is equally important. If you collect the data and you don't report it and you don't act on it, it is useless and actually is discriminatory. And then understanding and addressing the distinct barriers and disparity facing people of Black descent in Ontario. Law is important. You couldn't do all this without codifying it in law. The Ontario Anti-Racism Act of 2017 mandated and gave legislative authority to purposely collect race-based data to eliminate systemic racism and advance racial equality. It gives a specific purpose for collecting the data to eliminate systemic racism and advance racial equity. It requires government to establish data standards to make sure the data is properly used. And it sets rules to protect personal information as well. So it's very balanced. It looks at the potential harms and how to safeguard. And it identifies all the public sector organizations that are required to collect race-based data and stipulates whether the standards apply. And this requires the guidance and of various entities, and it needs consistent collection and management of this data, and in consultation with the Information and Privacy Commissioner and Ontario Human Rights Commission to make sure that the personal data protection and the safety of people whose data have been collected is protected. So this is the framework. Right at the middle of it is Black equity, based on 3 fundamental principles so that the population would thrive, they will recover, and they will develop resilience for against further trauma. We want Black leadership and infrastructure. We want anti-Black racism policy and action. We want a public health approach and whole government approach, not just one aspect of the government, and also race-based data and standards. Number 5, that's what we are focusing on. And if all this is done, we believe that we can have an equitable health and social outcomes. We'll be able to eliminate disparity. We'll have a culturally competent public services that are bias-free, that are evidence-informed, and that provide equitable access to services and support. I think this is a well-designed framework because it has equity at the center of it. Based on this, we recommend that the government of Ontario develops a race-based data action plan. And the action plan is critical. Collect the data, analyze it, report it, act on it, and show us how you're doing on it. Prioritize application by the Ministry of Health and Long-Term Care. Assume responsibility for ensuring that race-based data is consistently and regularly collected, analyzed, and reported publicly, and race-based data to be collected at OHIP registration, which is how people enter the system, and to raise funds in Black community, raise fund and resource for Black community to be the stewards in race-based data collection, analysis, and reporting. Sorry, I'm moving in the wrong direction. I just want to end with my summary slide so that we can have questions and discussion. Right. So systemic racism creates the health inequities that make it imperative that we collect and effectively use race-based data. I hope that I've made you, if you were concerned about race-based data collection, I've made you comfortable that we need them so that we can actually fight socially constructed racial policies. There has to be meaningful application and impact that can only occur if the data is applied to address disparities and trends in a timely way and in a significant manner. And the impact of COVID-19 powerfully illustrated for us why Black Lives Matter and why this has to be addressed now. And we in the Black community want transformation. We don't want just talk, we don't want just data gathering, but we want action that can lead to change and improve the health of our generation and generations to come. Thank you very much.
We'll take 2 or 3 questions, and there's a mic in the center of the aisle here. So does anyone have a question they'd like to pose to Dr. Adame? Could you come to the mic? Thank you.
Can you hear me?
Yes, I can.
Awesome. Thank you so much. It was a beautiful presentation. Just 2 questions occurred to me. One, I'm just wondering about the American statistics versus the Canadian statistics, because I assume we're different than the States. Similar, but not different, but not necessarily that different. And also, how does stats for ethnicity fall into this discussion?
Right. I think when it comes to the COVID-19 data, we knew that at the beginning of the pandemic, our data was not much different from that of the United States. And in fact, the UK also published the same data. But we are proud to say that the Black Scientist Task Force initiative actually helped improve those statistics. So although sometimes, and I feel, having lived in the UK many of my training years and interacting a lot with my colleagues in the United States, sometimes we Canadians tend to think that Canada is much better. I think that is a wrong assumption. I think we make mistakes all the time, that we think it is not as bad as it is in other places. But if you look at the data, we are not that better. And I think we should really fight as hard as we can, because the data is not clear. You asked about ethnicity.
Yes.
Whether ethnicity, yeah, I mean, I think it's not part of the data collection that is being done. But ethnicity also matters, because sometimes you can see some disparities and inequities based on ethnicity. And so I think if we're going to do this properly, we must be able to collect the data in detail and be able to analyze it, disaggregate it, and analyze it so that it can point us to areas where specific action may be needed.
Okay. Thank you very much.
Thank you.
Appreciate it.
You can make comments as well, not only questions.
My question is in terms of healthcare organizations, in terms of collecting race-based data, lawyers. There's always a legal component to that, and some are hesitant. And so there is an urgency that we want to collect it, and we'll have the purpose, intent all there, and then you present it, and then they say that it talks to the lawyers about it. So how does that work for organizations who want to pursue it, but then it's kind of left on someone's desk? So I'm curious what tools are available that we can help them move that along.
Yeah, I think we should not be put off by the due diligence that people want to, because what often happens in such initiatives, you only need one bad case of wrongful use of data, and that will blow the whole thing up. And so the initial hesitation and diligence is okay, so long as, like you're saying, we can make it clear what the data is going to be used for, what its limits are. Like we said, it has to be equity-directed plan. It has to be directed at removing disparities and inequities. If that is the sole purpose driving it, it gives it a narrow kind of framework within which to judge this. But I think the legal aspect of it is important as well, because if you don't, it's like in my clinical practice, if you tell a patient about a new treatment, you don't tell them about the harmful effects, they don't trust you. And so when I tell them about a new treatment, I make sure that I tell them all the known harmful effects. And in fact, rather than put them off, I have realized that the patients begin to trust you. That, oh, this clinician has actually warned me of the harmful effects. I trust this guy. I will try this medication. Whereas if you don't, and they go to find out then you lose their trust. And it's the same way, I think, when the legal aspect are being done, although we know that the legal system is so slow, it bogs you down. But I think it has to be done so that we are sure that we are heading in the right direction and the parameters for collecting the data are well protected. I don't know whether I've answered the question. Yes. Yes.
So I do work for an organization where race-based data is collected. It is an expectation of us, and it's something we've done for years. And I think within our system, the anti-Black racism, the equity, diversity, and sort of inclusion perspective for us has become a priority. And I understand, and I really appreciate this presentation. And you say you're kind of preaching to the choir, and you're talking to within our own community.
Yeah.
I think it's integral for us to understand how to within other medical sectors and within other fields, because the systemic racism that is being experienced can't just be addressed in one system without us all being at the same level. And I think that that's something that I've been experiencing with the role where I am. So I'm so grateful to see this presentation and how sort of the medical field is addressing it. These relationships with the health and well-being of our community. And I think if, we start at the foundational level, if you're not eating and sleeping, as you say, and, others are saying, how are you going to be able to provide? But if we don't have trust, I think that the focus that needs to be had.
The lived experience of treatment for my mother, and she did not get the treatment that she deserved.
Right.
And my goal with this artistic project is to help others be aware that these kinds of things happen.
Right.
And also to have discussions about ways we can be better informed and protect ourselves so that it's like you said, so it's equitable for everyone.
Yeah.
Having said that, I would love to know if the links to these reports and such will be provided so that everyone who may be interested can find them.
Right.
So I have been taking pictures so I can find some of them, but I think it would be great that that information is just shared with the community and still respecting the incredible detailed research that you've done. So respecting your educational property, but still finding a way to share. The other thing is monitoring. Sometimes when we have a task force, we have this organization, we have these opportunities, we go, oh, everything is taken care of. So my request or my question is, how can we start embedding the monitoring? Because like you said, and this you said as well, collecting it, protecting it, how can we also monitor it so that folks know that they can't just do whatever that they want? So that's one of my things, embedding and monitoring.
No, you are absolutely right. I think you've made a very important point, that the collection of the data is only the beginning of the journey. It has to be properly analyzed. And I can tell you, even in the analytical process, there can be bias. People can collect the same data and come to wrong conclusions. So the analysis has to be valid. Now, when you've analyzed and you've come to conclusions, you have to publicize it. Because you are right. If the Black community do not know that that data has revealed that particular information, then they will not be empowered to seek out for it. So it has to be publicized. It has to be in the public domain, because actually the Ontario Act is actually mandating certain public health, organizations to collect race-based data. It has to be published. But if it's published, it's being published with a view that action will be taken. And what are those recommended action plans? And after that, what is the monitoring? So it's a full circle, and I would not claim with the Black Scientist Task Force, although we are coming to an end, I hope that what we've generated within the city is actually a whole process of going full circle and being able to monitor and publish that data even to the community. So we have to find a forum or a place, a repository where people can go to and see this data and see the monitoring and evaluation process and what becomes of it. We are in this for a long haul. We've only just begun, and it takes all of us making allies with our other partners, the majority white community, to be able to address this. So thank you for your comments, and they are very well made, and they are very pointed as well. Thank you.
Thank you, and thank you to the task force and everyone who organized this.
No, yeah. This event is being live streamed, and we have some interaction with people who are looking online. So we have a question online, and the question is from Barbara Thompson. It says, Dr. Dame, index cases for SARS 2003 were managed differently and led to containment of SARS. How would race-based data change the fact that COVID-19 index cases were not similarly managed?
Well, I mean, I think this is not a race-based question at all. This is purely science and medicine, and therefore I don't know. My talk was not meant to address this, but I think what the question I was trying to allude to was that there were differences in our management of COVID-19, which was different from SARS. Now, let me make a distinction. SARS, the first SARS that hit Toronto was much more of a killer. It had a high mortality rate. Very few who had SARS-1 actually survived it. But then that was the virus's own undoing, okay? Because if people died soon after they contracted SARS, they were not alive to pass it on. Okay, so it was easier to contain it. A virus that is stealth, okay, the person passing it on may not have symptoms at all. It's within the community, it's within the household, it's going to work, it's doing things normally, but it's asymptomatic, but it's passing it on. It's a far more dangerous thing. So although the case mortality rate for COVID was lower than SARS, its spread was much wider and it became a pandemic. SARS-1 didn't become a pandemic for that reason. You isolate a patient in a place, you restrict them, you contain it. But COVID was stealth. The people passing, children will have it, they won't have symptoms at all, but they can pass it on. And that is why COVID was a much more challenging infection to handle. So there are biological differences that are counted for the differences in which we acted. High case fatality is bad when you get it, but for public health sort of situation like Ebola, if you are able to really contain it and restrict it, you can prevent it from becoming a pandemic. But when you have COVID, which may present in normal-looking people, healthy people, but can transmit the infection, you have a big challenge on your hand. And that was the problem we had with COVID. It was so challenging to contain the infection. So I hope that answers the question for the questioner.
We'd like to thank you, Isaac, for that enlightening and really important presentation. We're going to have a quick break, 10 minutes. So come back here at 11 o'clock. Yeah, come back here at 11 o'clock for our next session and get some refreshments and get your blood tested or a massage if you can do it in 10 minutes. See you back here at 11 o'clock. Hello, everyone. We're about to start next session. So please take your seats. And could someone make an announcement in the foyer there to let people know? Yes? Okay. Is Donna Pascal here? Donna? Oh, she's coming. Great. Okay, can we take our seats? Yeah, please. Okay, this session is a panel discussion, and the title is Structural Barriers to Black Health and Wellness, the Priorities, Addressing Black Social Determinants of Health. And it's going to be a panel. Each of the panel members will speak for about 5 minutes, and then there'll be a general discussion. I'll just quickly introduce the panel members. On my left, we have Paul Bailey, and Paul is a strategist, urban planner, and executive director at the Black Health Alliance. Please, thank you. And I think this is Nadine McKenzie. Nadine was diagnosed with stage 4 breast cancer in September of 2022. She's a writer, a mother of 2 young girls, and owner of the Melanin MRKT, a Black business incubator established in 2017. Welcome. Then we have Liban Jebrimichael, who is the executive director of the Taibu Community Health Center and a great supporter and collaborator with the Black Scientists Task Force. Next, we have Donna Fagan Pascal, who is the she's a Dynacor representative. She has, for over 18 years, experience in human resources, and the last 12 years serving as a senior HR executive with Dynacare. Welcome. We have Akwatu Kenti on our left, who is the driver, I would say, of the Black Scientific Task Force. Give him a hand, please. And our moderator for the day, for this session, is Donna Sinclair. She's a member of the Black Scientists Task Force and also Vice President, Clinical Care and Recovery and Chief Nurse Executive at the Center for Addiction and Mental Health. Welcome.
Thank you very much for that introduction. It's Dion Sinclair. It's like Celine, but I can't sing, okay? All right, so thank you everyone for being here. I am very interested in the answers to some of these questions. And I'm gonna start on the far left and come across right. You have 5 minutes. 5 minutes. Sometimes, Paul, are you gonna be passing the mic? Beside you? Okay. All right, so our first question is, what is one prior structural barrier and its impact on Black health and well-being? What's one structural barrier and impact on Black health and well-being? you're going to answer.
I wasn't prepared for the question first. But I think the way that I look at the structural barriers around Black health and well-being is obviously largely focused on the social determinants of health. In, a city like Toronto, we know that when it comes to things like poverty or low income, Black communities are amongst those with the highest unemployment, highest level of working poor, highest levels of children living in poverty, and we know that that's generational. And then we know the impacts of those things. It's food insecurity, housing insecurity, et cetera. So many of the kind of fundamental structures that underlie our health and our well-being. And so when if I'm thinking about the answer to that question, Dion, for me, it's poverty, how that ties into anti-Black racism, and the barriers to opportunity that creates.
Thank you, Paul. Nadine, same question. What's one structural barrier and what's its impact on Black health and well-being?
There's so many. The one that I will speak on, I think for me, is the lack of representation in healthcare. A lot of our healthcare is based on white people. So how their skin looks, how their body responds, test results are based on everything about them. And Black people in particular are fundamentally different. So there are certain tests that we will take that if it was done on a white person, those results might be cause for concern. But if it's done on us, it's not. And so we're getting treatment or we're not getting treatment based on things that are not catered towards us and our health. So I would say representation in healthcare is probably a great structure that is standing in the way of healthcare.
Yeah. No, thank you. I agree with you. It was 2022 when I'm a registered nurse. I've done even masters in nursing. I never saw myself represented in any of the anatomy books. And it was 2022 when I first saw a Black fetus. And so you're absolutely correct. Liben, same question. What's one structural barrier and what's its impact on Black health and well-being?
So from my perspective, just to add to some of the structural barriers that have been identified, and also coming from the healthcare kind of services representing Taibu and many other community health centers, I think how healthcare is organized and structured and health is actually defined, I think is also a significant barrier and one area where we're always finding challenges, and how healthcare responds to healthcare situations, even if there was no intervention from the community, how the pandemic response would have been delivered by governmental systems. So I think how healthcare is structured, it's always focused on the medical model. It's picking up people at the bottom of the cliff when people have fallen, have broken bones, or are dead. That's where the focus is when we're talking about healthcare systems, when we're talking about other social issues. For example, when we have community safety challenges in our neighborhoods, the response is always at the bottom of the cliff and saying we need more police, rather than addressing some of the social determinants of health and things that have existed for generations that has led for certain communities to be exposed to community safety issues. So I think how healthcare and social services are structured, that's where I think part of the problem we face and where we need to also bring about changes.
Okay.
Thank you.
No, thank you very much. What I heard you saying is we need to be more proactive, have more health promotion and preventative measures instead of reacting when something happens. Is that okay? Donna, same question.
Last year, we actually asked a panel of healthcare experts on Black History Month this same question. So I'm going to borrow the question from them, their answers. And I think what they shared with our organization was access. And if you have difficulty, so if you have a lot of new Canadians entering the country, access to a family doctor is a big challenge. And then on top of that, if you're lucky enough to get access to a family doctor or a walk-in clinic, you get a requisition. And now you have a requisition to go get your testing done, but you have to work certain hours, maybe midnight to whatever. You don't have the time or the ability to find a convenient place to go get this work done. And so their recommendation to our organization was, try and bring the testing where they are and make it convenient in hours or in areas that allows them to get, maybe at a church or somewhere where people, have the convenience for more mobile access. So that was some of the recommendations they had shared with us.
No, thank you very much for that. We saw that with COVID and at the vaccine clinic and health and wellness, it went to the community in the centers. So people, it's convenient. And we know if something's convenient, we'll get to it. If it's out of the way, not gonna happen. Akwatu, I'm gonna ask you the same question, and then you're gonna answer the second question and pass the mic back down. So first question, what's a structural barrier and its impact on Black health and well-being? And then what's needed to improve the health and well-being of the Black community?
So to the first question, I would say that systemic anti-Black racism, which acts through the determinants of health and amplifies the determinants of health for Black people, housing is made worse, unemployment is made worse, poverty is made worse, education is made worse. So that's when the anti-Black racism acts through these determinants, making conditions worse. But then on top of that, anti-Black racism acts independent of the determinants through the criminal justice system, so that you experience stress and distress from the racial profiling you experience in life, walking while Black, driving while Black, which actually adds to the chronic conditions that Black people tend to have, diabetes, high blood pressure, whatever, which have no roots in Africa. People in Africa have lower rates of diabetes, lower rates of hypertension than the Africans in the Black diaspora. But it's the pressure of living here that actually makes our health conditions as bad as they are.
Okay, and what's needed to improve that?
So commitment from the community for help, for real and meaningful help seeking when problems present themselves, understanding that our health really is our wealth, our riches, but commitment from the government, so that when they talk about healthcare being the best, that also includes health equity. We learn, I would have had a pre-pandemic answer to that question and a post-pandemic. And post-pandemic, I would tell you, government commitment to equity is essential. And what we've seen is that when that commitment is explicit, it works. We can reduce these disparities. We don't have to be talking about them 40 years from now. Our children don't have to be talking from them 40 years from now if the commitment is there. And of course, you should always look back at yourself when you point the finger at the government and say, you got to do that. But what we have to do is make help seeking and self-care real things that we take on.
Okay, thank you. Now, nobody asked me, and for those guys, they know me. I don't know why they put me up here. But I believe a structural barrier is also, Black community, our financial health. Because we got 2, 3, 4 jobs. Why? Where do you invest your money? It's your car, your purse. Some people got I won't even say. They got so much stuff but no life insurance. And something happens to them and their family suffers and the whole cycle starts again. You are mentally drained when all you're stressed about is finances. We're in a recession. It affects your health. So y'all just take care of that. All right, next question, your answer. What's needed to improve the health and well-being of the Black community?
I would say that, for me, I think there are things, oftentimes I find sometimes with healthcare, we tend to blame the individual. You need to eat better. You need to lose weight. You need to, here are all the list of things you need to do. And I think for our community, I think we should stop blaming. And I think we should start informing and giving people options. So for example, if somebody is overweight, If you go to your doctor and say you're overweight, they tell you, oh, go eat vegetables. And listen, I know this, I've had this conversation many times, but go eat vegetables and go eat. And it's not a reality in a community that you have to eat a certain way or culturally you eat a certain way. But there are tools out there that I think clinicians can support us with more proactively, tools to help us actually, medications or things like that that can help control some of these conditions. And I think there's sometimes a hesitancy. And if we're not aware of those tools or aware that there are things out there that can take care of our health or, for example, like diabetes, there's a lot of things that doctors can do in advance of someone, getting into a full-blown type 2, as a pre-diabetic. So I think informing us so that when we go to our doctors, we can advocate and we can ask for those tools and ask for the additional support. So it's not the burden placed on the individual to try and figure it out themselves.
Thank you, Donna. Next is Lieben.
Yeah.
Lieben.
Thank you.
I wrote it.
So I just will follow up from what Brother Akwatu said. I think in addition to the commitment, or maybe the commitment should also include a significant review or restructuring of how resources are allocated when we're talking about healthcare. The type of services or supports that needs to be resourced, the way they are resourced, and from community's perspective, we have been ready to bring about change. We need the commitment of the government, which would include resourcing and policy changes, and resourcing support services, healthcare services, the way it can be delivered to the community, the way the community can receive those services. We have very good examples. I think today's conversation and the outcomes that we have seen as part of the engagement with the Black Scientist Task Force, some other initiatives that have happened during this through the Black Health Alliance, many community health centers who have been involved in making sure that COVID information, COVID vaccine, COVID testing were being made available to communities where they are. We have experiences, we have demonstrated that it can be done. We need the structure, the resourcing, and the policies to help us continue to do that. And, it can be done. It should be done. I think we need to move to the stage where it will be done.
Thank you very much for that. Nadine,
Well,
what's needed to improve?
I completely agree that equity is needed, but I think as people of color, we all know that if we're waiting on people to help save us, that we're not going to be saved. So for me, I think that one of the most important things is dialogue. We don't have enough of that in the community. I myself, again, being diagnosed with breast cancer, when we hear breast cancer, we think like, oh, our auntie who got breast cancer, or our auntie got breast cancer, beat breast cancer, got breast cancer, again, died from breast cancer. That is the end of the story. But we need to get into the dialogue about what the actual symptoms are for people of color, how people are treating it, how people are living with it, what the actual expectancies are. Like even as of right now, the Canadian government doesn't even have any hard statistical facts about Black breast cancer or even survival rates. So I think we amongst ourselves need to get into the dialogue of discussing what health actually looks like, not just your auntie who got it or your uncle who got this, but actually like, what are they doing? How are they living with it? How is it diagnosed? Is it genetic? Should we get tested? What are we doing? So I think we really need to create more of a dialogue and things of this nature, task force, and discussing it. I think that will be the start that ignites everybody, because I would prefer to hear it from my family, my friends, than.
Absolutely.
Yeah.
Thank you so much. And that was very evident when the Black Physicians Association came to different places and had the conversation, listened to people that were hesitant. I had my own child listen to somebody from that Black Physicians Association. She went and got her vaccines. She wasn't going to, but now we can travel as a family. Paul, last question again, what's needed? And after this question, I've got presentations from Donna and Nadine. So Paul, what's needed to improve the health and well-being of the Black community?
It's a big question. I think I agree with Nadine. nobody's coming to save us, right? So you really have to develop the capacity and the strategy to save yourself. And I don't think it's that people don't care or the allies don't care. I think they do care. They just care about themselves more. So when it comes to the resources that need to get allocated, you can see the whole debate right now around the mayor should be here later, but $1 billion going to police plus, these are the fundamental things that shape the way that the society gets shaped and people's access to care. So I think the thing that we need to focus on, or at least the perspective that we take from the Black Health Alliance, is one of focusing on the social determinants of health, things like income, poverty, housing, food security. Challenges though, that, these issues are massive and we're tiny up against these things. And so, the work that we're trying to do, I think across the board, is to build the kinds of coalitions, the kinds of influence, the kind of power that allows us to, kind of hold our health, stronger in our own hands.
Okay, thank you very much. So we've got two presentations. Donna and Nadine, I'm not sure whose is going up first, but I know these are going to be very impactful. So, yep. Here you go.
I'm not sure. Do you know if they're putting up the slides?
Slide one.
Do we have the slides for Donna? Is that it? No.
We do or we don't? Okay.
Okay.
It is testing and how it can improve the social. So it's a presentation, type 2 diabetes, access to testing and how it can improve social determinants of Black health. If not, I can wing it. I'm good at that. I'll do my best. Do they have it? Yes, no?
There you go. That's it.
Is that it?
Yeah.
Okay. It looks very different.
Yeah.
Could we go with the
Say next slide.
next slide? At the beginning, yeah, maybe. How do I go backwards? The red one?
Okay, yeah. You only have to go
Google. Sorry to hear about the diagnosis. I hope you're doing.
Where is it? Can you go to the beginning of the diabetes one?
Well, those are my slides. Do they want me to go first?
Maybe you can go first.
Yeah.
Okay, all right, let me do. Oh, here I am. Okay, yes, there, thank you. All right, that looks like what I wanted to talk about. Okay, I have 5 minutes. So thank you all, and it's really an honor to be here to speak to you today. And I'm very fortunate that I work for an organization that is very passionate about the well-being of the community. And I have to say, my CEO here today, Vito Ciceretto, and we were talking about allies today, and I'm fortunate to say he is truly an ally and has really, supported our organization in making sure that we can support the Black community. And so I'm really pleased to have the opportunity to talk to you today. It's particularly about diabetes. And DynaCare, we specialize in diagnostic testing. And we're headquartered in Brampton, and you may be familiar with, going to our laboratories for various testing, and you may have visited one of our clinic locations before. In our own backyard, and we're based in Brampton, but we're all across Canada, 1 in 4 people in Peel region, which is one of the most diverse communities in Canada, is impacted by diabetes. And when you look at the Black population, we're 6 times more likely to have diabetes or be pre-diabetic. In the next couple of slides, I'm going to show you some really impactful data of some work we've been doing, outreaching to the Black community to really understand what is the prevalence of diabetes in the community and making sure that we're able to connect them with support and access due to the fact that diabetes is associated with numerous comorbidities and serious conditions if it left untreated. So we typically, every year, we do a campaign called DynaCare for Diabetes. We completed a campaign last in the fall, and where we hire influencers in the Black community, in the South Asian community, to go out and promote information around diabetes and encourage people to go get their A1C blood test done. And so we did about 81,000 tests in the province of Ontario in that campaign period. 68% of those test results showed that people in Ontario were suffering from abnormal results. Many of those individuals were pre-diabetic and did not know that they had the propensity for diabetes. And 71% of the participants were around the age of 40, under, and then predominantly 55% female and 45% male. What was staggering is that because we were really focused on making sure that we were looking at communities that were suffering from issues of health equity, and we focused on the Black community in our campaign, these are two areas in which we focused on. For example, so I'll just give you just a snapshot of some of the campaigns we did. So for example, we went to the Seventh-day Adventist Church, which was predominantly a Black church in Brampton, and we performed 48 A1C collections, and 52% returned as abnormals. And many of these individuals were, first of all, we had to convince them to do the test, so I don't know, we had to really sell it, and then, ended up that many of them found out that they were abnormal. And the same thing with the city of Brampton. We did a wellness fair for the Black community there. 79% of those test results showed it abnormal. And so this information is powerful information that people now can get informed. They get their results back on a digital app. They get connected with a campaign doctor. So when that doctor actually calls them, follows up, and makes sure they have a family doctor or they have support to help address their condition of diabetes there. So Black, African, Caribbean, South Asian people suffer from, are considered to be one of the high risk factor groups. And our organization is very committed to working and fixing this problem. I do want to share my own passion story. This picture of my brother, unfortunately, he's no longer with us, and he was a diabetic. And diabetes is very prevalent in my family. My mother, my grandmother, numerous family members have diabetes, and my brother was one of those. And unfortunately, he succumbed to the comorbidities associated with diabetes at the age of 43. So this is not only just something I'm doing for my work, I'm just very fortunate to be in a position of influence and an amazing company with amazing leadership that's very committed to looking at addressing the issues of diabetes. And so that's my inspiration right there. So how can we help? I just want to share, I think, I shared a little bit about having more access and more accessible testing, I think is really important. Information is power. I also think education is really important. The more we sit with, and you talked about it, conversation, more we inform people about the importance of testing, of knowing what your A1C levels are, right? Which is looking at your average blood sugar over a period of time. It really gives people powerful information to go out and address their health as soon as possible. Because diabetes, especially type 2 diabetes, is something that can be corrected for some, if you catch it early enough, if you make certain changes in your lifestyle. And as our community, we're catching it way too late, and we're catching it until we've got comorbidities that you can't reverse. So our passion is to try and fix that, work with different organizations to try and solve for this. And I think, I think today this is a great example of how communities like our community coming together, informing each other, and looking for solutions in the future so we can all live a better life. And our commitment is life is precious. So thank you.
And Nadine, I think your slides just continue. Is it the green button?
Yes.
Yeah, the green button to advance.
There you go.
All right, perfect. Ignore that for just a moment. My name is Nadine McKenzie. I'm 40 years old, and 5 months ago, I was diagnosed with stage 4 breast cancer. Like many of us, I don't have a family doctor. My family doctor died when died in 2017, right before the pandemic. And I've been on the Ontario Connects list since that time period. I still don't have a family doctor. And then, of course, we have the disparities of COVID. And we stopped doing testing for those 2 years during that time. So a lot of people were not able to get their cancer screening as they would normally do. For my story in particular, in early of September, I got a pain in my chest, at the top of my chest. I didn't really think anything of it. I just assumed that it was like a chest pain. I thought it was my period, my breasts were tender, and I had been feeling this pain for about 2 weeks. And after the second week, I finally decided, I think I should go get this checked out. And I just tried to go to a walk-in clinic. But as I'm sure we all know, walk-in clinics hours have changed drastically since the pandemic and post-pandemic even. And so I tried for about another week and a half to get into a walk-in clinic to see if I could get something tested. And then naturally, I became my own Google doctor. And I went online and I started to Google the symptoms that I was having. And as I said, well, it's breast pain. So naturally, the first thing I'm going to think is, let me go look at and see what's breast cancer. And what I was met with were several posts that look very similar to this. And they show us all of the signs that we're supposed to look for when we have breast cancer. So we've got the skin changes. And as you can see, this is a white breast. We've got the skin changes. We've got nipple discharge, general pain, which is the only symptom of these symptoms that I actually had. The shape changes, the nipple changes, and the lymph nodes. Now, I am a mother, and so my breasts have changed dramatically anyways. So it's very hard to identify a certain change when your body's constantly changing anyways. The next slide I'm going to show you is a picture of my breast. My nipple is covered, but I just want to give you guys a heads up. So you can understand exactly why it is imperative and important that we really get tested. There we go. This is my breast with stage 4 breast cancer. I think everybody can see that my breast looks fairly normal. Based on the 6 signs, I have stage 4 breast cancer. Okay, that is the final stage of breast cancer, and I don't have any of those symptoms. And that's why I have become an advocate now at this time to make sure that I'm advocating for people who are looking for signs that I was talking about the disparities and why it's important that we have these diets. So before you guys, the other thing to talk about is the fact that in our particular, we don't actually talk about things like breast cancer. We talk about our auntie that got breast cancer, who died from breast cancer, or our auntie who beat breast cancer. It came back again and then she died. We don't talk about the people that are living with breast cancer. And we certainly don't talk about people who look like me or are young like me who are getting breast cancer. And that's why we don't think that this is anything that we have to worry about. We're not avidly going to our doctors and saying, hey, I need to go get checked. I need to demand a mammogram. I need to demand a biopsy because something's not right. And they're going to say, because since I got diagnosed, I have gone online and I have been advocating so much for everyone to go and get their mammograms and go and get checked. And a lot of people are coming back to me and saying, well, my doctor said I'm too young. My doctor said I have to wait until I'm 45. My doctor said I had to wait until I'm 50. I'm 40 years old. To me, that sounds like a death sentence if I have to wait that long. And so it's very imperative that we get tested. So that being said, prior to my breast cancer journey, I am a writer. I write content, I write songs, and I write novels. I am also the owner of Melanin Market, which is a Black business incubator. When I started Melanin Market in 2017, it was because of the lack of representation that I found for people of color, for entrepreneurs. So we created an incubator so that entrepreneurs had shelf space to sell their products and so that Black consumers had the ability to purchase things that represent them. So obviously in that nature, I see the same disparities in healthcare. I'm going to then advocate for that as well. So what I have been doing since I was diagnosed was trying to reach out to organizations. And I was met with the Olive Branch of Hope and Tropicana Community Services. And so what we will be doing is creating a drop-in mammogram clinic because of the feedback that I received about Black women who were not able to get healthcare, where their doctors were blocking them and saying, no, you have to wait 5 years. My cousin went to go and try to get tested, and she was met with, you have to wait until you're 50 years old, even though she has an immediate family member that was recently diagnosed. So in the month of April, we will be conducting a mammogram drop-in clinic. There are more information to follow. If you would like to follow up on that, you can go to London Market or to my personal page, Mac_sauce, for any updates of that. But putting all of you get up and go to your doctors and demand a mammogram, demand a biopsy. Do not take no for an answer. Go to the hospital, lie if you have to, make sure somebody sees you. Do not, this is your health, and I do not want to see any other women in my situation. And the other thing we're going to talk about as well is that you can still live with cancer, and that's the most important thing. When I tell anyone that I'm diagnosed with stage 4 breast cancer, I am immediately met with pity and heartbreak, and that is not what I need, nor is that anything that I want. You can live with breast cancer. There are people that have been living with stage 4 breast cancer for well over 20 years, but we don't know that because we don't have these conversations and we don't have these dialogues. People look at me and they say, well, you look healthy, you look so great. I refuse to look any other way.
Healthy food, is critical and important. So unfortunately, we know that in Toronto, 30% of Black families versus 12% of the general city live food insecure. And so there's a significant portion of the population that doesn't have access to the dollars that they need to eat healthy and good food on a consistent basis. And over time, that has a profound impact on your health and leads to things like diabetes.
Yeah. And also, you've got children going to school hungry. How are they going to learn? How are they going to act? I'm hungry, right? So it does really impact the next generation. Malnourishment impacts the next generation. So, yeah. Quick.
Yeah, I just want to sort of add to that question or the answer to the question, because what I often hear is that I'm eating right, exercising right, I drink a little rum every night or I actually do that on the radio, and I don't need the vaccine because I'm doing everything. I even run every day or every other day. And so one of the things I like to emphasize is if you're eating right, exercising, sleeping right, that's great because it's your body that actually does the work in fighting the infectious disease. And you still need the vaccine, not because it's not either or. The vaccine is actually a tool that your body uses to kill the virus. And so it's not one or the other. Eat the broccoli, eat the spinach, callaloo, whatever, but get vaccinated also. Then, you bolster, you got all your armaments in place to fight that infectious disease well.
Okay. Thank you. So we've got time for 2 questions. There's a mic right there at the front. If anyone has questions, comments, they take compliments as well. Yes, yeah, go ahead.
Well, one thing I found in particular when I was diagnosed was I had asked the doctors, like, hey, is there anything that I should be eating or anything like that? There's no answer. Eat whatever you like. Do whatever you like. Like the way that we don't discuss food, or the medical like industry does not discuss nutrition even as an act of healthcare, is a huge problem. And I'm not saying Dr. Sebi or anything of these natures, but like, for example, cancer feeds off of sugar, right? Cancer cells have 48% or 3 times the amount of sugar than any other cell. Why am I not being advised not to have sugar? Why am I going for chemo and being offered juice and cookies while I'm sitting there getting treatment? So us taking the time to actually learn about health, like we were talking about diabetes. If you have sugar and then you eat fiber immediately after, you will actually help break down how the spike in your sugar. But we're not even talking about managing the foods that we eat. We're so far removed from understanding our bodies and nutrition that we have. I think that's really important that we.
Absolutely. Nutrition is so very much important. Yes.
Can I just add one more
Yeah.
point? And also, I think whenever we get the chance or we're lucky to get some advice around nutrition, a lot of the information provided does not relate to us because the type of food that we're being advised, just like the Canada Food Guide, we don't relate to those kind of things. And also, I think what we eat is also important as part of the conversation.
Okay. Thank you very much. Yes, go ahead.
I'm Dr. Lorimer, and I was a family physician as well as an emergency and respiratory physician. One of the things that we should be using is our WhatsApps. In the last 3 years, I was inundated with things of cures, real good nutritional cures. And I would say in the Black community, we have to help ourselves by what we eat and encouraging people to eat more fruits, vegetables, and especially the vegetables that are so common in our community. So please use your WhatsApps to spread the good news and the good nutrition.
Okay. Thank you very much for that. Yes.
So I think maybe as an information is there are a lot of, or a few, let me say there are a few community health centers in the city, in the GTA, that are providing this kind of services. Many that we work with are also very particular in addressing these issues around the Black community. So Taibu being one, Black Creek, Rexdale Community Health Center, Parkdale Queen West CHC, Regents Park, Women's Health in Women's Hands. So there are many CHCs, and in Hamilton we have the Hamilton Urban Core CHC, that, and then I think in Brampton we have Wellford, where we have significant number of Black communities and programs and services, including nutrition education, primary care, health promotion programs that are specific to Black communities. So reach out. And we're also going to be working. We work with the Olive Branch already, but we'll connect as well. Thank you.
Okay, so I would like to thank very much the panel members for their wealth of knowledge, sharing all your wisdom. Oh, we've got one more.
I just feel like I have to take the opportunity to encourage all of today's participants to take advantage of the wellness panel that DynaCare is offering. So we have a female wellness panel and a male panel. And so, for example, for males, we'll be providing PSA and for both males and females, lipids, A1C, hemoglobin, all essential indicators, vitamin D, all essential indicators of health. So please take advantage of that with our booth. So I just wanted to make sure people were aware.
Okay, as a registered nurse, I'm going to encourage you to do that, especially all the ones without family doctors. I know you don't want those annual physicals, but this is your opportunity. Take advantage of it. Again, thank you very much, panel members. We now have a very special guest. We have someone who's introducing. Is Denise Campbell? There you go. Thank you, Denise.
Introduce you. Introduce who?
Hello, everyone. Good afternoon. It's so wonderful to see you. My name is Denise Andrea Campbell, and I'm the Executive Director of a city division called Social Development, Finance, and Administration. Long name, but really just a division that is trying to ensure that as the city work our very hardest to listen to community, to provide the kinds of supports to the organizations and to the community leaders to uplift the city and to provide the kinds of services that are responsive to our needs. So it's an absolute pleasure to be here today and to hear. And it is my even more pleasure to introduce and welcome two champions at Toronto City Hall who have a great interest, they think, in the dialogue today and in the health and well-being of our community. So first, I'd like to welcome Councillor Moyes, and of course, my pleasure to welcome Mayor John Tory.
Well, good morning. And Denise, thank you very much. And I should say I hope that you join me in thanking Denise. She is one of the outstanding leaders at Toronto City Hall in the public service. And, you know, she gets it. I hope while politicians are more controversial, that I get it. I want to have a very honest conversation with you this morning. But before I have that brief, honest conversation, because time is scarce in this agenda, I want to say thank you because the work that was done, this gathering today is not entirely, but largely at the initiative of the Black Science Task Force and all the people who are involved in helping us to deliver a vaccine equity program that I think helped Toronto to do a better job than most places in the world. And I just want to thank them. I had a chance not only to meet with them, but to actually listen to one of the seminars they gave to people, Black Torontonians, to help them deal with some of the issues they had. I'll make reference to that in a moment with respect to the vaccine program and COVID in general. And I can just say it was an eye-opener for me. And you might say, well, at your age, university, been around all these years, you learn every day. And I hope that my remarks today will tell you that I learned something from all of that. But the bottom line was that those particular initiatives that we undertook as a city, and uniquely as a city in many respects, saved lives. They saved lives, hundreds of lives. And I think that's what we're here to do. At the end of the day, whether it's people to be kept safe from crime or to be kept safe from things that might befall them as pedestrians or in any way, shape, or form, our job in government is to save lives and to make lives better for people. And I will just tell you that that entire program that we put in place was something that saved lives and made a big difference to the well-being of people in very important communities in the city, including Black residents of Toronto. And I should just say to you that a lot of that took place, and he's not in politics anymore, and he doesn't need me to butter him up. But Councillor Joe Cressy, who's somebody that will be known to a number of you, he had a great deal to do. I mean, he became, and even at City Hall, where there are no parties, there are people who are kind of in the current administration and part of it, and some people who may not be so much. He maybe was not one of those ones so much, but he became my partner during the course of the pandemic, together with Dr. Davila and others who would have seen television all the time. And he was the one that was at the forefront of making sure that we had a number of these programs that took very particular account of the circumstances of different people in the city and delivered for them on a different basis. And in the result, led to a better result for them and a better result in terms of saving lives and thus a better result for the city. I do want to thank all those who are involved in all that. I'm here today as somebody who's very gratified by that because, you're proud of the fact that your city did better. We didn't do perfectly, and there were so many people who, because of marginalization and for other reasons, fell between the cracks, as it were, with respect to COVID or a host of other things they were falling between the cracks on before COVID. But I was gratified nonetheless at the fact we figured some things out and did something differently and took some innovations to achieve a better result. And so the question becomes, we learned lessons from that could be applied going forward. And I would say to you, that's where the frustration comes in, because I did, but you find yourself in a position as the mayor of a local government, sometimes frustrated in your ability to help deliver on an ongoing basis, because the fact is the way our country is set up. Cities are the best at delivering things. We're local, we're on the ground, we're in neighborhoods, we have a network of people we can employ, as we did in this case, whether it be from community health organizations or from, from local pastors of churches. I think, as you know, on the vaccine equity program, one of the things we tried to do with the advice of the Black Scientist Task Force is to have people who were trusted. I mean, I will tell you, during the pandemic, I learned of things I didn't know, and I was a history student in university. I did not know because, and if you think about this, maybe why somebody like me from my admittedly very privileged background, I don't say that as a point of criticism of myself, I grew up the way I did. But the fact is, I learned about some of the historic abuses that had been perpetrated on Black, more Americans than Canadians, but things that had happened that were horrific. I don't think most Canadians know about them as a part of history. And why that would, on an intergenerational basis, breed mistrust for the healthcare system and mistrust for authorities. You know, where if I went on television, which I did every day, and said you should get vaccinated because it would be good for you in terms of staying out of the hospital and saving your life and saving the lives of people who were, your elderly relatives and so forth. But I would understand why there would be people out there for a variety of reasons who would sort of say, I'm not so sure about that, given where that's coming from. And so we worked to employ, when I say employ, to utilize people who were more trying to deliver some of that message and reassure and comfort people that were experiencing some of this intergenerational and even current, mistrust of the healthcare system. But I also recognize the fact that what we learned from that lesson of the COVID experience was that we had people, and again, I knew this part, where you had people who had to go to work when everybody was told they had to go to work because their job, which they needed to keep, was a job that could only be delivered in person in a grocery store, in a long-term care, in a hospital, driving a bus, on an assembly line. They had to use the bus to get there, which was a congregate, setting where they were more exposed. Beg pardon? So we learned, and that of course is why COVID, as you started to see the early results, impacted some neighborhoods more so than others. And so we learned by investing there, as we did, when frankly money was quite free flowing during the pandemic to address what was a crisis, that we could achieve better results. And that's where the results are tied to the future, because we saw when you made those investments that you got a payback, not just in terms of lives that were saved, but in terms of people being better off than they wouldn't have been without them. But I think the frustration that I have comes in the fact that, yes, cities and the city of Toronto in particular, thanks to capable people like Denise, who has a very important job in this regard, we cannot do the job we can do delivering on those kinds of things for communities that are more marginalized unless there's a complete rethink of how all these things are funded. And the funding has to come from the other governments. If you think about it, and I think you understand this, everybody does, that the way our system is set up, and I've referred to it recently, you've probably heard me, as a system that was set up in 1867 that gave cities very limited abilities to do certain things. But we were nonetheless the best at a lot of those things because we're local, because we know the people as individuals that we're dealing with, whereas the other governments are just a little bit further away. What we don't have is the financial resources, either because they're given to us on a consistent, reliable basis by the other governments, or because we're given the tools necessary to raise that money. We basically raise money through the property taxes, which, to be quite candid, and I think you understand, were not meant to pay for the healthcare system. They just weren't. They don't grow with the economy. Property taxes are what they are. They were meant to provide for hard services delivered to people. And that's what they do. They deliver solid waste and make sure the water is turned on, say, and the ambulance and the police and the fire department and so on and so forth. And so I just ask you to help me, because I wanted to try and through these remarks indicate that I understand the lessons we learned from COVID about things like intergenerational trauma, but just as importantly about upstream investment, how you can invest upstream and get better results downstream, are very applicable to a lot of what I think you're talking about today, which is how do we keep the successful results of COVID going on to make sure that communities that are marginalized get more support and culturally sensitive support and to address better outcomes, not just on things like COVID, but on education and opportunity and kids, being all that they want to be. And the answer is going to be if we all together rethink how we do things. Because if we just keep going the way we're going in terms of us being the best suited to deliver these kinds of services that we're trying our best to deliver, but we don't get the partnership with the other governments to make sure that they say, fine, we're going to give you the money because you know how to best deploy it to produce better results on these kinds of things, then the results may be marginally better because we introduce things like our community crisis response. And some of the people here today from Taibu are our partners in delivering that, so that instead of the police coming to deal with people in distress, you have mental health professionals. And we were sensitive enough in picking the partners we were delivering that to know that Taibu could help us make sure that when it came to big issue, Black mental health, that we had people who at least would be able to deliver a culturally sensitive response, as well as having a non-police response to people in distress. So when we have the opportunity to do it, we get it and we try and do it under the leadership of people like Denise, and frankly, me too, because my heart is there. But I also deal with a practical reality, which is how do you do this in the context of trying to pay for it, trying to make sure it's integrated with the efforts of the health system, for example, overall. And that has proven to be very difficult in this country, where everybody seems to have their, their sort of piece of turf that they sit on, and they guard that, as opposed to saying what we did during the pandemic. Why did we succeed in the pandemic? Because we worked together, and because we said we're not going to be concerned about where the money comes from. We're going to be more concerned about the results that it achieved and who is best to deliver, using that money to deliver support to people. So that wasn't at all what I intended to say. I have some notes here, which I know that they said very nice things about everything that I meant sincerely, which is again where I started to say thank you to all the people who are involved in what I think was a very successful initiative. And I hope it was successful not just in producing better results for COVID, but also that it will teach us the lessons that we need to learn, and that we can come together and deliver things better, including the upstream investment, including the partnerships we forged with organizations like Taibu to do better for people, all people, so that no one is left behind. So I thank you for giving me this time this morning, and I wish you well in the rest of your day's discussions. And again, thank you to everybody who was involved in what was a very successful undertaking.
Thank you, Mayor Tory. Now it is my honor to welcome up Councillor Moyes. He's the councillor for this area that's hosting the event today.
Good morning, everyone. It's so great to be here. As mentioned, my name is Councillor Chris Moyes. I am the proud city councillor for this ward. And thank you, Mayor Tory, for your kind words. Always inspiration. And also to Denise, who's also a member of our community here. I just wanted to say that it's really great to have this event here today. We know that as Black people, we don't talk about our health, right? Culturally, we don't talk about it. We don't talk about counseling services, none of those things. I arrived here at 11:15 this morning. I had an opportunity to go around to the pavilions and speaking to some of the people behind the booth. And I found myself speaking to Anthony, who's manning the prostate cancer pavilion there. And he was saying things to me and showing me the stats of, the high rate of prostate cancer among Black men in various parts of the Caribbean and East Africa and elsewhere. And there were no stats actually for here in Canada or Toronto, which I found to be a bit surprising. And so for me, who's now 51, didn't tell anyone, I have never thought myself actually getting a prostate cancer test. And through speaking with him, who is a little older than I am, but he said in 2015 he actually got a prostate cancer test and it came back positive. And his brother also got a test and that came back positive. And he looks healthy now, and I'm not sure if he's cancer free or not, but that was a very moving story for me. And even listening to some of the panelists here this morning, and the lady get her to her stage 4 cancer, that too was very front and center in mind, and I was moved by her story. So the takeaway from me here today is that when I leave here, I need to go get a prostate cancer test. And I hope that the rest of you also do that as well. And for me, being now chair of Toronto Public Health, it's important to lead by example and to amplify the voices of not only the Black community, but everyone here in the city of Toronto. So I did invite Anthony to reach out to me and perhaps present at Toronto Public Health at some point, so that my colleagues on the board and also Dr. Davila can hear and to listen and to learn as I do, because again, we're never too old to learn. So again, it's great to be here, and thank you so much for inviting me. And I hope we can continue to have these sort of gatherings, in years to come, because it's really, really important. And I'm happy to hear that we're able to also have people online listen to learn as well. And hopefully over time, we'll get more people here and get this space filled up, because I think it's important to do that. Anyways, I've gone on long enough. Thank you so much. Have a good afternoon.
Yep. One more question. Yep.
Our Black community. I do see mental health within the young people, within families where I go to work, and I'm thinking to myself, where is everyone? Well, I'm there, but today, where is the topic? Where is the committee? Where is the, how are we going? I am concerned about the level of schizophrenia. I see a lot of this. I go to hospitals, I see all of this. So who, when we move from here, how are we going to address the issue of mental health within our youth, within our homes, within our, I just don't know, but it is out there. Please, I need someone to help me help these families that are struggling with mental health and unstable housing, unstable.
Thank you.
Please, I don't know who to, I don't know who is.
Yes, so I was actually doing the morning wrap up for today. We actually have a more full program in the afternoon. We'll be addressing mental health and, you know, lessons that the pandemic has taught us and where we need to go in the future. We're also including mental health supports as one of our key recommendations to to government officials. So we are addressing it, and we'll be speaking on it more this afternoon. So thank you for your comment. Quick question. we're gonna break for lunch. Don't you want some food? Yes. So, this is a community event. This is what it's all about. I do encourage you guys to, speak your truth.
I think we have to address the fact that there is a real economic cost to wider society when we neglect vulnerable populations, right? Um, my friend said Black people, homeless people are mostly Black. They're also mostly queer and trans, right? And those are the people who are filled in shelters, who are spreading COVID and Mpox, and it will continue until we recognize that to the wider society, there's a real economic cost to neglecting vulnerable people.
Absolutely. Thank you. Okay, everybody. So I just wanted to do a recap of the morning. We spoke on race-based data and the importance of collecting race-based data in the health space. We also talked about barriers to access for Black communities in the health and wellness space. And we touched on addressing anti-Black racism in the healthcare system. So, thank you so much for joining us. I'm mad that I'm seeing these nurses' stations empty, so I want you guys to make sure you get some blood work done today, get a massage. Again, we are breaking for lunch, so go out and have some food. And I did want to pass on a message that CBC is looking for somebody to speak on their struggles with finding a Black doctor. So, finding a doctor, period. So if that is you, please reach out to them in our media section. And yeah, everybody get your blood work done. I have a quick thing to say about the blood work. We're testing vitamin D today. Vitamin D is a nutrient that we as melanated people are notoriously deficient in. It is also a test that is not covered by OHIP. So it's something that you would come out of pocket to pay for, but we're offering it for free today. So please use these services. They're here for you.